Hello, everyone. I'm Sarah with Cork Healthcare. Thank you for joining. We're just going to wait a couple more minutes for some more people to join, and then we will begin. Thank you. All right, we can go ahead and get started. Just so you know, this presentation will be uploaded to SlideShare as well as YouTube if you want to view it afterwards. The topic regulations recap will be presented by Vice President of Business Development of Cork, Jonathan Everett. And Jonathan, we are ready when you are.
All right, thank you kindly for the introduction. Let's go ahead and get started. Just to let you know, everyone, today's main focus is going to be on meaningful use, and it's a topic that's probably been beaten to the ground a million times, but it's still a topic that really needs to be covered in detail and making sure people understand, what's going on with the latest and what are the new, regulations behind it. So. We're going to get started. And from a nice introduction, my name is Jonathan Everett. I've been around the healthcare IT arena for over 12 years. I currently serve as the Vice President of Business Development for Cork Healthcare. I live in Portland, Oregon. It's my favorite place pretty much in the entire world. And so we're just going to jump right into the meat and potatoes. So, meaningful use overview. I'm pretty sure most of us know what this is, but, set of standards defined by the Centers for Medicare and Medicaid Services, always called CMS. There are large financial incentives for using certified EHR technology, obviously in a meaningful manner for electronic exchange of health information, and you're submitting clinical quality measures, CQMs. So, everyone is also aware, most likely, of, 3 specific stages here in meaningful use. And, stage 1, data capture and sharing. Stage 2, advanced clinical processes. And 3, improved outcomes. And so when you think about that, it's like, meaningful use itself has a very specific goal. And it's not just to use cool new computers in your office, but specifically to try to make changes in our healthcare system and hopefully not only just improve outcomes, but lower costs and everything along those lines. If anyone here is a Medicaid provider or a Medicaid office, you do have the option of, doing your adopt, implement, or upgrade meaningful use. I had worked at a practice in San Francisco for a long time where we were probably about 70% Medi-Cal, so the AIU was really helpful for us. So, and again, Medicare reimbursement, you can see you pretty much had to get started a long time ago in order to get the full incentives for meaningful use. Otherwise, you start to lose significant amounts of money. Whereas in Medicaid, as I mentioned before, it is way less strict, and the incentives go on for a much longer time because they recognize that you are, trying to take care of an underserved population. So you can see now it's like even now coming up into 2015 and 2016, you can still do your AIU and get the majority of your incentives. So meaningful use eligibility. So doctors of medicine or osteopathy, doctors of dental surgery or dental medicine, doctors of podiatry, doctors of optometry, and chiropractors. So in order to get paid for meaningful use, you need to be some of the above. And then there's a lot of talk now, it's like, what's the difference between meaningful use stage 1 versus meaningful use stage 2? And, meaningful use stage 1 was really designed to be kind of like I'd call it like a beer sampler of what's going to be coming down in the future. So you had 13 core measures, you had 5 to 10 menu measures, a total of 18, whereas in meaningful use stage 2, you had 17 core measures, 3 to 6 menus for a total of 20. So, and if everyone remembers when, the stage 2 final rule was released, there was a lot of like, whoa, the percentages jumped up a ton, and there were some specific items that made it very difficult. Specifically, is the patient portal added as a core measure? And, I always go back to my examples of, when I worked in San Francisco, and we had a senior population, mainly, many dual eligible patients, and many who didn't speak English, let alone read it. So, we found ourselves in, quite a few precarious situations where, the patient portal was, required for meaningful use stage 2, but it was, it's almost meaningless in terms of how patients would do it. So there are some other minor changes there where you can see there's a link which you'll be able to access later, but anyone here who is from the next-gen world, getting your patients auto-enrolled into the patient portal is kind of a bear of a scenario, but we can get into more of that later. So what's important, though, and really important, are the penalties. And everybody always asks, like, are the penalties worth it? And, that's something you and your organization have to decide if you want to go through the headache. But, data year 2014, penalty year 2015, you're losing 1%. Same thing. Data year 2015, penalty year 2016, you're losing 2%. And this continues an additional 1% each year. I mean, that can add up pretty quick. And so, one of the scenarios that always came up for us was, we have a provider who's on the cusp of retirement, only going to be around for a couple of years. Is it really worth their time and their effort to go through the stages of meaningful use if they're only going to lose like a 1% penalty because they're going to retire? And you have to go back and forth with your organization and help the providers make the best decisions. I was always a proponent even of always going for meaningful use regardless if you're going to retire or not, just specifically because you can get the big bonus and the big bonus up front, and then your practice is in a better position to either transition hands to a new younger provider or to sell to a new younger provider because you have all the infrastructure already in place and it's easier for them to get started and makes your practice more attractive. But then the same question happens, a new provider's like, I don't really want to do this. This is, a waste of time or so on and so forth. But again, the recommendation for any provider is always to do their best and try to do it. So here are some of the rule updates. If you were scheduled to demonstrate stage 1 in 2014 using 2011 edition CEHRT, then the 2000 stage 1 objectives and measures. Using 2011 and 2014 edition, 2013 stage 1 objectives and measures, or 2014 stage 1 objectives and measures. Using 2014 edition cert to do 2014 stage 1 objectives and measures. If you're going into stage 2 in 2014, then the 2013 stage 1 objectives and measures, If you're using 2011 and 2014 edition cert due, you have 2013 stage 1 objectives and measures, or 2014 stage 1 objectives and measures, or stage 2 objectives and measures. And then using 2014 edition cert to do, stage 2 in 2014 is 2014 stage 1 objectives and measures, or stage 2 objectives and measures. I just said about 7,000 words in 2 seconds, and when you look at it, it's really confusing, but if you really understand these rule updates, it really puts you in the driver's seat and being able to make the best choices or whatever is necessary, not the easiest, but the best practice for what you need to do for your practice moving forward. So to use any of the methodologies before with an asterisk, you must attest that you could not fully implement 2014 edition cert for the EHR reporting period in 2014 due to delays in 2014 edition cert availability. These can be delays with the certification, issues caused with defects, or delay in ancillary products like reports and HISPS. So, with delays, again, you can take advantage of those if it really makes sense for your organization. Like, say you may not have had enough time to upgrade to a cert, a 2014 edition cert availability system, and it really, if you can use them, I would say you probably should. Medicaid providers do not need to start attesting until 2016 to receive full amount, kind of what I had just mentioned previously. We just started working with a new client who is in the midst of trying to get everything on to, next gen KBM version 8.3 and EHR version 5.8. They have yet to do any meaningful use, so they're kind of convenient in the sense that for 2015 they can start their AIU and get their full first year of incentive payments and then not have to worry about the measures starting until 2016, or even if they wanted to wait another year, they could. So you can do AIU for the first year for first payment, and then you do not have a sequential year requirement. Say if you attest in 2015 for AIU and you don't hit your stage 1 measures in 2016, that's okay. You can continue to attest and not get a penalty for missing any of those years, whereas Medicare is much more strict. So, using the correct MU version. If you are on a 2011 certified system, you must use 2013 MU1 requirements. If you are on a 2014 certified system, you must use 2014 MU1 requirements. This means the patient portal is a core measure. It's very important to understand that. So if you were very aggressive and you did the right thing and you upgraded, you may have some more things you have to worry about. If this is your first year of testing, you need to attest by October 1st, 2014, your face penalty in 2015. Hardship exemptions for 2015 have to be submitted by November 30th. And keep an eye out for the 2016 hardship exceptions. But if everyone remembers, they've changed that exception date, or the hardship exception date, probably about 17 trillion times, and different reasons why you can do it. But it's important to know that the new hardship exception date is November 30th of this month. So you still have time if you need to make that call. If this is your second year of testing, you must attest for a quarter by end of year. If you are on a 2011 certified version, you attest using MU Stage 1 2013 requirements. If you are on a 2014 certified version, you attest using Meaningful Use Stage 1 2014 requirements. This requires a patient portal. Again, very key, you have to use that patient portal. If this is your third or fourth year of testing, you must attest for a quarter by end of year. You may either, if you are on a 2011 certified version, you attest using MU 2013 requirements. If you are on a 2014 certified version, you attest using MU1 2014 requirements. Again, this requires a patient portal, or attest using Stage 2. Some words of caution. Providers who are testing for their fourth or fifth year of meaningful use in 2015 will have to attest for the full year. Well, unless CMS changes their minds again, which, again, people are saying, what's your 5-year plan for your healthcare IT department? It's like, well, you can't really give a solid answer anymore because everything changes all the time. I mean, look how many times we've probably all planned for ICD-10 and haven't been able to, really follow through on those plans or any of those measures. So, and then for Medicaid providers, not all states will have their attestation portals ready in time. Contact your state for more details. And I can tell you right now, even in California for Medicaid or Medi-Cal, they're still getting their portals set up correctly. So overall, that's our standard meaningful use recap. And again, there's a lot of different items to talk about. There's a lot of different, different version for this and different scenario for this. So if you have some specific questions that I didn't cover regarding meaningful use, please feel free to send me an email. I have no problem taking the time to get you the answers that you need for your organization. And if there are any general questions without any major specifics, we can take a couple now. So let's go.
That's it.
All right, doesn't sound like we have any specific questions, so apologize for how quick the presentation was this time around, but next week we'll try to do some more interesting content regarding maybe some value-based reimbursements and so on. So any questions, please send it to me via email, and thank you for attending the Insight.